So let's get going. So I want to introduce you guys. If you already know Dr. Allo, he's a board-certified cardiologist. He specializes in preventative cardiology. He is a professor of medicine at Midwestern University and Ohio University. He's also a personal trainer, which is pretty unique for a doctor, and he's an author. So thank you for joining us tonight, Dr. Allo.
Yeah, thanks for having me.
Why don't you just start off by telling us a little bit what preventative cardiology is, because that is a unique field.
Yeah, so I obviously do everything. I mean, a cardiologist pretty much does everything. We do the cardiac catheterizations, we do stents, we do pacemakers. There's all kinds of things. There's heart failure. There's all kinds of subspecialties now in cardiology. Preventative cardiologist's job is to prevent you ever from needing a cardiologist. Many of my patients say things to me like, I wish I would have met you 40 years ago. And, the thing is, you don't want to have to see a cardiologist because you have to see a cardiologist. You want to see a cardiologist when you absolutely need to. Like, the problem is we get a lot of patients that now have had a heart attack or stroke already, or they're in heart failure, or they need a pacemaker or something, and now they need to see a cardiologist. We would like to make it so that you do all those things correctly, and I'm sure people in primary care probably feel the same way. If you follow your doctor's recommendations, you eat a healthy diet, you exercise, you treat all your underlying medical conditions that you might need to treat, you do all the correct things, get enough sleep, do whatever, hopefully you never need a cardiologist. Obviously, there are some people with genetic problems that almost no matter what you do, you're going to need something. We got people with really high blood pressure, high cholesterol, high blood sugars, diabetes, all kinds of weird genetic anomalies in cardiology and, other fields. Some of those people, regardless of what you do, are still going to need to see a cardiologist regardless. But the hope is that for the vast majority of people, 60 to maybe 90% of people, if you do everything right, stay as close to your ideal body weight as possible, exercise every day, eat healthy, nutritious foods, and do all the things that we mentioned, hopefully you'll never need a cardiologist. For most people, that would probably be true. Obviously, there's a genetic component to most of these conditions, and, there's not a whole lot that if some people can do. Most people, if they did everything we stated, will probably be fine. But some people are going to have some genetic issues where they're just not going to be fine, even if they did all that.
Okay, perfect. I guess that brings me, to my second question. I mean, there's this hot topic now, I guess, probably not for you because you're a cardiologist, but when someone is assessing their lipid panel, traditionally we look at things like total cholesterol, LDL-C or LDL concentration, triglycerides, but now there's this focus now on ApoB. Why don't you tell the audience a little bit about what ApoB is, and I guess what we're seeing in the United States, it seems to be, at least from a cardiology perspective, a little bit more of a slower adopter in terms of the guidelines using ApoB. I know LDL-C is what's been studied the most, so therefore our guidelines are based off of LDL-C. So tell us a little bit about what ApoB is and why you feel like it's been kind of slow. The guidelines are kind of slow to respond in the United States to catering to ApoB, which is a much more accurate marker than LDL-C.
So I think people just don't understand the difference. They think that we're hiding this magical thing called ApoB from them, and we're not, using ApoB because we're like, we don't understand it enough. But ApoB, I mean, the best way to do it is just show you visually. This is a lipoprotein molecule. Can you hear me okay? I got like some feedback going on.
I can hear you.
I don't know if there's, maybe mute your microphone while I'm chatting because I'm getting like some squeaky noises. But either way, for those watching, this is a lipoprotein. Oh, that sounds a little better. Lipoprotein's job is to traffic cholesterol and triglycerides back and forth, depending on which ones they are. There's high density ones, there's low density ones, there's even chylomicrons, there's remnants, there's all kinds of things. Without getting too deep into the woodwork, let's say this is a low-density lipoprotein, all right? This is what it looks like. On the inside, the yellow stuff is the cholesterol, the turquoise is the triglycerides. Some have more triglycerides, depending on which ones they are, but some have fewer and have cholesterol. Cholesterol's job in a lipoprotein is mainly structural, is to hold it open so that it can carry more triglycerides. Depending on which one of the lipoproteins we're talking about, chylomicron's job is mainly to deliver triglycerides to adipose tissue, which is fat tissue, and muscles for energy. HDL particles, if this were an HDL particles, their job is mainly to bring cholesterol back, but mainly they give it back to an LDL particle. Let's say this one's LDL. They give it back to an LDL particle to bring back to the liver to eliminate. So LDL particles, for the majority of their life, or at least a significant part of their life, they're actually helping bring back cholesterol to the liver. So people call these bad lipoproteins. For a vast, huge part of their life, they're not actually bad. They're actually helping in something called indirect reverse cholesterol transport to bring cholesterol back to the liver to be eliminated. All the cells in your body make cholesterol. A lot of people say, well, don't we need cholesterol? Well, yes, you do need cholesterol, but every cell in your body makes its own cholesterol. You don't need extra cholesterol circulating in circulation. That's when it becomes a problem. So ApoB, so when we do a lipid panel, like you said, we get, actually, it's even more interesting than what you said. You get a total cholesterol, you get a HDL, you get a triglycerides. Those are directly measured. You would get the total cholesterol, and by total cholesterol, we measure all of the yellow. It's inside all of your lipoproteins, all of them, whether they're IDLs, LDLs, VLDLs, HDLs, whatever. So we get a total cholesterol. We subtract out the triglycerides, the turquoise, little molecules, let's say in the HDL. HDLs don't have very many, but let's say in the, other molecules, IDLs, VLDLs, whatever, we take them out. Most of them are LDL. We subtract out triglycerides, and we subtract out HDL. And then that leaves you, we don't directly measure LDL. You do a calculation to figure out, well, of all of this total cholesterol, we took out the HDL, there's non-HDL, which is what's left over. So let's say your cholesterol is 200, we subtract out the 40 that's in an HDL, you end up with like 160. That's your non-HDL cholesterol. You do a calculation where you take triglycerides divided by 5, subtract that number plus the HDL cholesterol from your total, and that approximates your LDL cholesterol. So it's not really measured because it would take too many steps, and it's a little bit harder and more expensive to do. But when we measure your LDL cholesterol, let's say now this is a LDL particle. Let's say this is an LDL particle, and this is the cholesterol that's in it. So when we look at a lipid panel, an LDL cholesterol is just this.
Right.
An ApoB is this blue structural protein that dips in and out of the structure. Let me put these halves back together. It's a blue structural protein that kind of dips in and out of the structure of the low-density lipoprotein, which helps hold it together. Now, the reason we are doing ApoB, or we think ApoB is more accurate, is because it's giving us an actual cholesterol particle count. And it's the total cholesterol particle count, or gradient, if you want to call it a gradient, that makes them more atherogenic. When you have an arterial wall, for example, you've got like an arterial wall, the more LDL particles that are floating in the bloodstream in the lumen, the more likely they are to get in and cause atherosclerosis. So we could order something called an NMR, which I don't know if you've heard of these, but they give you actual particle counts. Mm-hmm. They're okay. They're not always as accurate as an ApoB, because ApoB is like in the immunological assay, which measures just that lipoprotein B particle. NMRs can be somewhat inaccurate in certain scenarios, but they'll tell you you have 2,500 LDLs, you have 1,500, or actually 10,000 HDLs, you have this many chylomicrons, this many IDLs, LDLs, VLDLs, whatever. It'll give you an exact number. Some people like ordering them. They're expensive. They're not really needed. It's nuclear magnetic resonance measurements of these particles based on size. The problem is some of the sizes can overlap and they're not super accurate. But an ApoB gives you an exact measurement of your total particles in a concentration gradient in milligrams per deciliter, as opposed to nanomoles, which is an actual count of the actual number of particles, nanomoles per liter, or whatever. So you're looking at an exact particle concentration gradient. The higher the concentration gradient, the more of them will get into your arterial wall and be retained and cause atherosclerosis. So, looking at an artery, this is the normal open lumen here. The higher your particle concentration gradient, the more of them get in here, dump their cholesterol in here, and then eventually, later on in life, it gets tighter and tighter. And this process, unfortunately, takes decades. A lot of people are like, well, I've had high cholesterol for the last 10 years and I'm fine. Well, it takes decades. 10 years is generally not enough, unless your cholesterols are astronomical. But generally speaking, if your LDL is like 120, 130, which no one should be, but let's say it is, it's going to take till you're like 50 or 60. Most men get atherosclerosis somewhere around 65, most women around 75, but we don't ever want to get there. So a preventative cardiologist, generally speaking, tries to make sure you never get to that point and lowers your LDL cholesterol, treats all your risk factors, gets your blood sugar down, your blood pressure down, smoking, your diet cleaned up, eat a correct, healthy type of diet that doesn't raise your cholesterol, so that you don't end up needing a cardiologist, when you're 40, 50, 60, 70, whatever it might be. The whole point is to not have those problems. Well, people say, well, aren't you just ruining your own income because you're trying to prevent heart disease? Like, you don't need to have heart attack patients. There's plenty of work that cardiologists do that's nothing to do with atherosclerosis. I mean, you got congenital issues, you've got like hypertension, diabetes. I mean, I'd rather spend all my days teaching people how to eat right, diet, exercise, build muscle, build strength, than sit there and be like, let me put a stent in you and let me eventually, treat the heart failure that you got from having multiple vessels plugged up or whatever. So I think people don't understand that. They think that our job is to keep people sicker so that we can profit off of them or some weird nonsense like that. And I get it. It's not everyone. It's just some of the weirdos online that, have nothing better to do than just criticize everyone and everything that are trying to help you. I'm sure you get a lot of comments like that too, that it's not in your best interest to cure people. A patient cured is a customer lost or something like that. I don't know. They got all these like little acronyms or something to say. But generally, that's kind of the difference. LDL, when you get an LDL cholesterol on your lipid panel, it's a calculated amount of cholesterol in LDL lipoproteins, which would be like the inside here. And then when you check an ApoB, you're getting this blue structural protein. Think about it like like if you're standing on the side of a highway and you are looking for cars that have a blue oval on the front. Those are Fords. If you see a blue oval, even from far away, you know that's the Ford. That's the ApoB. The passengers inside are like the cholesterol.
Right.
So that would be one way to kind of look at it that hopefully makes sense.
Okay. So not to get too nerdy with this, but I do like to dive in a little bit deeper into this.
Oh, we can dive real deep if you want. I mean, there's 520 pages worth
I
that we just published in a book if you want to go real deep. But I think
we're going to talk about that at the end. But so just for the viewers, just so they know, that ApoB, it tags all of the plaque-forming particles in our arteries. So that's what we use now. So when we're looking at the LDL-C, like you said, which is the concentration of cholesterol within the particles, it's more of a blunt instrument. ApoB is much more accurate, tagging all particles. So on that note, when we're looking at, there's some conflicting data out there, and I think more emerging, we're seeing now that you see, when we say big and fluffy versus LDL, and for the viewers, being a large LDL particle with presumably more cholesterol inside versus a small LDL particle which has less cholesterol. The theory being that the small particles are able to penetrate, or through transcytosis, which is just an active process of going inside the wall, that they can get into the wall easier and they stay there more. But from the data, from what I'm seeing, and tell me if you how you see this, it doesn't matter if they're big and fluffy or small. All LDL particles themselves are atherogenic, meaning that they do cause plaque formation. So the theory that if you have large particles, when you look at these NMRs, and you think that they're large, you're not necessarily safe. All of these particles are bad. What are your thoughts on?
Yeah, so this is
the word bad, but they can form plaque.
They're all atherogenic because don't forget, part of their lifespan, they're actually helping return cholesterol out of your arteries to be eliminated. So they're all we like to say they're all potentially atherogenic. So if all of those particles that you mentioned, whether they're LDLs or VLDLs or IDLs or anything, any ApoB containing particle, which is quite a gamut of particles, they're all potentially atherogenic at a high enough concentration gradient. If we get you down to physiologic levels, which is somewhere between 10 and maybe 20 milligrams per deciliter, not going to happen. There's a genetic condition called hypo-beta lipoproteinemia, where some people are born with really, really low LDL cholesterol, like in the 10 to 15 range. These people will never have atherosclerosis no matter what you do, no matter how diabetic you are, how much you smoke. You're going to get a lot of other stuff, but you're not going to have atherosclerosis. So the size thing that people are discussing was this theory we had, probably back in the late 90s, early 2000s, where it was, maybe the big ones don't get across. So the gap junctions between endothelial cells, and again, like these are, the one cell layer, there's like a one cell layer. I don't know if you can see it. It's like a light pink color. That's the endothelium. It's a one cell layer. There's gaps between those cells. Anything under 70 nanometers can get into the cell wall and then be retained and cause plaque formation. So all LDL particles generally are between 18 nanometers and 24, maybe 25 at the most. That is like way less than 70. So if I showed you two LDL particles, this one is 25, this one is 18, can you actually tell the difference between the two? I have an even medium-sized one. It's virtually like you can't tell the difference between an 18 and a 22. Most are around 22. Some are like 24, some are like 19, 18. So they're all very, very tiny. They all get across, even by passive diffusion. You don't even need to be, they don't even need to be like, sometimes a cell, and sometimes it's called endocytosis, where they can like engulf the particle and bring it in. They don't even need to do that. That's a more active process. Even passive diffusion, like these things can just get through the gap junctions because they're wide open. They can just pass through. You don't even need anything fancy. They just pass through. They're under 70 nanometers. They all can get through quite easily without even anything complicated. So we used to think that somewhere around 2005, 2008, more and more data was available. The labs love this particle size thing because they could just sell you a bunch of nonsense and make millions. Doctors order it, the labs run it, and the patient gets charged $300, $600 instead of a $2 test. Literally, an ApoB test would cost $2, maybe $8 at the most, depending on where you live and what lab you're going to. The nice thing about ApoB is you don't need to be fasting at all. You could have just eaten. We can check your ApoB and we know exactly what your number is. It's not going to change or fluctuate, which is why we've been checking those more, because the patient comes in, they're like, I forgot, doc, I just ate a bagel. Well, we can't get you a fasting lipid panel, but here, just go get an ApoB. Don't worry about it. It's not that big of a deal. And then they're like, okay, I'll just walk over to the lab. You get a little bit more compliance with blood work if the patient knows they can just walk over and get it done no matter what. So the size thing definitely did not pan out very much. Labs will still do it because they like making money. And some of these online, I don't want to call them bad names, but online idiots that don't know what they're talking about. They want to sell you a dream that, if you have the big, large, fluffy LDLs, you're fine. There are plenty of people with big, large, fluffy only particles. Like, for example, kids with familial hypercholesterolemia. This is a medical condition called FH, or familial hypercholesterolemia. These are children by age 13, depending on what genetic one they have. They could have atherosclerosis. By age 5, they could be dead from a stroke or a heart attack. But most don't make it past 20 untreated, depending on how many of the alleles they have. They all have the big fluffy kind. And they have no inflammation, no smoking, no diabetes. In fact, the incidence of diabetes in them is less than the general public. Their diabetes insulin resistance is 1.25% versus the general public, which is 9.5%, maybe 10% at the most. If you count all insulin resistance, it's between 15 to maybe 35%, depending on how you categorize it or what method of measuring it you want. But that's still insanely low. All these kids will be dead by age 20, some by age 5 or 6 or 7 at the most, if they're homozygous familial hypercholesterolemia, and they all have the big, large, fluffy kind that are supposedly okay, and obviously they're not.
It makes total sense. One other thing, and I know I saw a video that you did with a podcast you did with your favorite Paul Saladino, and I think there's this clustering effect where you have these ideas, coming in clusters. People that are on do the carnivore diet and seed oils, etc. Something to help fit the narrative. So one theory being the whole oxidized LDL, and I just don't see a lot of literature that supports this at all. And is it even used functionally in cardiology, looking at oxidized LDL?
Nobody checks oxidized LDL. This is also something that the labs did. Like somebody will experiment with something. Like science is always evolving. In the late 90s, again, same thing. They're trying to find better markers. Like we found ApoB. We're trying to find something else. They looked into these oxidized LDL particles to see if maybe they can become a good marker. And there's nothing wrong with being curious and trying to figure things out. So they checked and they said, oh, well, people that have higher oxidized LDL, maybe there's a trend towards atherosclerosis where if you don't have it, you're fine. Well, it turned out that wasn't true because all LDL particles were atherogenic, whether they were oxidized or not. Now, the other thing I'll tell you is that almost no oxidized LDL particles exist in circulation. You check it, and it's almost minimal. The second one of these things oxidizes, your immune system takes it out of circulation. Your liver completely eliminates it, and you do not have oxidized LDL floating around. Now, I will tell you that when an LDL particle gets in here and is inside once it passes the endothelial layer and gets in the intima, your body notices a foreign object that is toxic and shouldn't be there, and it will send macrophages and immune cells, and it'll signal the immune system to come and get it. That's when reactive oxygen species and things like that will come oxidize it. The LDL particles will all aggregate, they'll collapse, fall apart almost. The cholesterol is released into the intima, and then the macrophages come and gobble it up, and they become foam cells, they become necrotic. Decades later, they get calcified, and it crystallized and calcified, and you end up with bad outcomes because eventually the lumen, instead of being wide open, gets tighter and tighter and tighter, which leads to all kinds of problems, heart attacks, strokes, peripheral artery disease, all the nasty stuff. You can accelerate it if you also smoke, and you don't eat vegetables and fruits, and you don't exercise, and you're diabetic, and you're hypertensive, and you're overweight, and you keep piling more things on.
Right.
It becomes, you accelerate it. Like an analogy, I forget who said it. Imagine you're in a car and you're heading towards a cliff. You're going to fall off that cliff eventually, right? So you're either hitting the accelerator, going faster towards that ending, or you're pumping the brakes and slowing down to try to, prolong your time on Earth. So that's one way to look at it that I feel is accurate. You're trying to prolong your lifespan and health span and not accelerate it by doing a whole bunch of things that would just make it worse. The best way we now can completely eliminate heart disease by simply eliminating ApoB or LDL cholesterol, whatever you want to call it. That we can at least take away the number one cause of death. It keeps going down every year. Very few people die of heart disease now, even though I wouldn't say that because it's still the number one killer. But let's say there's a 90% reduction in deaths from heart disease if you go back to the 1930s, 40s, 50s to now. Still high on the list of killers. Probably it's still number one, but the number of deaths from heart disease every year as a percentage of total deaths keeps going down, which is real good. There's more people surviving, let's say, with or living with heart disease than prior decades, and it improves every year with newer stent technology, newer therapeutics. Now we have medications, these PCSK9 medications. They've become super popular. We now can get almost everybody down to an LDL cholesterol of like 10, 5, 0, 20. We can get people down in insanely low numbers.
It's incredible that the way that technology is going. Let's zoom out a little bit. I think the audience gets the point that ApoB, it's one of those things that we know now that it's not just the number that we're looking at freezing it in time, it's your time of exposure. And heart disease is something that is silent. You can't feel plaque building up in your arteries. You have to be checking this and being proactive about it. So the name of the game is getting your ApoB down as low as you possibly can. So I know the listeners want to know, we talked about lowering ApoB. We know that having an ideal blood pressure, not smoking, those are all things to minimize your risk for plaque buildup and atherosclerosis. What are some natural things that you can do to lower your ApoB to to the best that you optimally can, to your optimal range?
So I have a blog article on my website that says 11 ways to naturally lower your cholesterol, and we'll go through them. There's some that have like a minimal effect, but I'll still mention them, and there's some that have like a whopping effect, and I'll mention them. The single biggest way, the biggest effect size, when we do studies, we look at effect size. The thing that has the biggest effect size is diet. And by diet, it's generally one thing. It is reducing saturated fat intake. For those of you not sure what saturated fat is, it is fat that is solid at room temperature. These would be things like butter, bacon, lard, fat on steak, tallow, ghee, coconut oil, any fat that's solid at room temperature. Liquid oils that are liquidy at room temperature, most vegetable oils, olive oils, things like that are totally fine. They are more calories if you're trying to watch your caloric intake. Obviously, fat has more calories. It's 9 calories per gram versus only 4 from carbs and proteins. So be careful with that. But the thing that has the biggest effect size would be reducing saturated fat intake if you eat a lot of it. So some people are like, well, I don't eat a lot of butter. I don't eat a lot of these, chicken skin, steak, ribeye, ribs, whatever. I eat mostly fruits and vegetables and maybe some salmon here and there. Okay, then in your case, it's not going to have a huge effect. But most people on a standard American diet who eat ribs on the weekend, put butter on everything. I'm just making this up. Maybe most people don't eat that way. But if you eat that way, where you're eating a lot of saturated fat, the biggest reduction in LDL ApoB is going to be from cutting out saturated fat. That's like without question. There's almost no other thing you can do to naturally bring down your ApoB any more than just cutting that if you eat a lot of it. If you don't eat a lot of that stuff, not going to have a huge effect size. It will still reduce your LDL cholesterol 10 to 15% maybe if you clean up your diet a little bit more, but generally unless you have a horrific diet, it's not going to make a big difference. Other things that help are fiber. Fiber does compete in your intestines for absorption because plant sterols are like cholesterol is a sterol. It ends with the word sterol. So when you eat cholesterol, and it's not even cholesterol that you eat, it's all the cholesterol. This is another thing that people don't understand. They think that your gut's cholesterol is cholesterol you've eaten. It's not. It's all the cholesterol that's made in every cell in your body. It's trafficked in these guys back to your liver. Your liver puts it in your intestines. 90% of the cholesterol in your intestines is cholesterol your body already made. And most of that gets reabsorbed. That's the problem. The amount that you eat is really not that consequential. Most Americans do not eat that much cholesterol. I mean, unless you eat like tons of egg yolks and shrimp and stuff, but and octopus, things like that. Americans don't generally eat that. But generally speaking, most of the cholesterol that ends up in your intestines is your own cholesterol that you made somewhere else. And a lot of it gets reabsorbed. Now, if you eat fiber, it is a plant sterol almost, and it competes with cholesterol for reabsorption. It can lower your LDL 1 to maybe 5%, depending on the studies. That probably is the second biggest effect size. Exercise generally doesn't reduce your cholesterol. There's some nuance to it because if you're running more than 20 miles a week, it could. But like realistically speaking, no one does that. So if you're thinking like I'm going to start exercising by walking every day or jogging a few miles a day, it's not going to lower your cholesterol. Not smoking definitely helps, but it's not going to lower your cholesterol that much. Eating more fruit, fiber, vegetables, things like that. I think we mentioned like fruit on top of that, it has a lot of fiber in it, obviously. What else? I can't remember all 11 other things. Well, I mean, stuff like that. Getting better sleep, not because the sleep's going to lower your cholesterol, but it'll reduce your overall cardiovascular risk, reducing stress levels, things like that. Stress levels have been shown that if you have less stress, can sometimes reduce cholesterol. Also, like not a lot, like 1%, nothing significant. But all the normal stuff that you think of, socioeconomic factors definitely can lower cholesterol. If you're coming from a neighborhood or a part of town where you don't have access to, food that's low in saturated fat, and you're eating mostly like convenience store foods like Doritos and chips, it might have more saturated fat than other foods. Definitely that could be a problem. But eating nuts and legumes and beans, like the Mediterranean style diet stuff. Somebody I think asked in the comments what's the healthiest diet. It's a Mediterranean style diet, which is kind of like all the stuff we mentioned: fruits, beans, nuts, legumes, lean meats, seafood, poultry. Avoid saturated fat. Don't drink much alcohol. use olive oil if you need oils. Those kind of things make a huge difference in reducing heart disease, cardiovascular risk overall, not just because they lower your cholesterol, but definitely lowering cholesterol. If you can get it down to physiologic levels, it almost completely eliminates the heart disease factor from your, scenario. But a lot of the things we just mentioned, most of them have a smaller effect. If you had to take one thing away, it would be just cut saturated fat. That has the single biggest effect size. It's just whopping effect size compared to almost all these other things. Like I said, exercise, almost no effect unless you're insanely active, like, 20 miles a week of running or, going crazy, which is really hard to do. But generally speaking, cutting saturated fat is going to have the biggest effect size when it comes to lowering cholesterol. Now, if you don't eat a lot of that, probably not going to have a huge effect. You're just going to need medications.
And I think what you're talking about, I think what Dr. Aller is talking about, he's mentioning someone that is essentially eukcaloric. They're not eating abundance of calories. Obviously, if they're eating excess calories, then you're going to have higher triglycerides, et cetera, insulin resistance, which will drive up those numbers as well. But if we're, speaking apples for apples, someone that is trying to maintain their weight, they're not eating excess calories, what are types of foods that we want to avoid, or what foods that we can add in? I think this is what you're talking about. Is that correct?
So just to add a little bit of nuance to that, because that's absolutely correct. If you're eating at caloric maintenance or in a calorie deficit, you'll generally be fine, assuming you're eating a healthy kind of diet. The diabetes thing or the insulin resistance thing, if you are in a calorie surplus and have the genetics for diabetes, the problem is, like, you just because you're in a calorie surplus and you're overweight doesn't mean you're diabetic. This has been proven, like, in multiple studies. I mean, you have to have the genes for diabetes to be diabetic. We have plenty of 400-pound patients whose A1C is like 4.1, and they have immeasurable, fasting glucoses and insulins. They're just not diabetic, and you're just not going to get it. But if you are diabetic and in a calorie surplus and overweight, then sure, your triglycerides will go up. Even by proxy, what happens in diabetics is the plasma residence time of LDL or ApoB containing particles goes up a little bit, which is why their risk goes up, because they have a longer plasma residence time of their ApoB containing particles, which raises their LDL cholesterol, which is why they have higher risk. It's because of the higher overall LDL compared to what it would be if they didn't have the insulin resistance. It's not because of the actual insulin resistance or diabetes directly. It's because you're having higher cholesterol than what you normally would if your insulin resistance was controlled or you didn't have it. So there are very thin people that have very bad type 2 diabetes. We all have a 103-pound, little lady or guy, and they need like 15 meds to control their diabetes because they have really bad type 2 diabetes genetics. And, it's not that common. It's rare, obviously, but there are all kinds of extremes in between. So depending on how bad the diabetes is, it does increase the plasma residence time of your ApoB particles, which is why your risk goes up. And that is something that needs to be managed either through weight loss, being in a calorie deficit, like you said. Building muscle can definitely help. Or if none of that really is helping, then you'd obviously need diabetes medications. I mean, that will help, but you still have high insulin resistance. You will need medications in that scenario.
Absolutely. And not to go off on a rabbit hole on this, but another thing that I've been looking at closely is looking at something called a lipoprotein insulin resistance score. So,
yes,
which I find to be very interesting. And from the research that I'm seeing now, this is a much more sensitive marker than looking at something like a hemoglobin A1C, HOMA-IR, et cetera, because believe it or not, the lipoproteins and insulin resistance are baked in with one another. Someone doesn't necessarily have to have insulin resistance to have high ApoB. I'm not saying that, because there are plenty of people that have high ApoB and don't have insulin resistance, but we're seeing your lipoproteins change whenever you're developing insulin resistance. Like the LDL particles size is getting smaller and you're having more of them, but we're able to see this through this LPIR scoring to see if you're showing signs of insulin resistance well before your fasting insulin, well before the HOMA-IR, hemoglobin A1C. What are your thoughts on that? Yeah,
absolutely. LPIR is, like you said, the most sensitive early detection for insulin resistance. And it is an NMR. It's that nuclear magnetic resonance way of measuring particles. And this is probably the only time So for me, I don't order it a lot. I used to order these NMR lipo IR, things. It measures your chylomicron VLDL size versus the size of an LDL versus the size of an HDL. It can, quote unquote, detect insulin resistance decades before we normally can. But, like we have ways, like the problem is like the cutoffs are too high. Like we use a cutoff of 100, fasting glucose to tell someone they're pre-diabetic, and then 126 for diabetes. We use A1C 5.7 versus 6.5, to tell someone they're pre or diabetic or whatever. And you don't need to wait that long. So you don't have to wait till somebody crosses the threshold. But an LPIR can be done. It's expensive. No insurance pays for it. So I stopped using them. It's, patient gets a $900 bill, they want to kill you. So, but yeah, it is. And there are other ways. The HOMA IR is also another way of doing it. You look at your fasting insulin versus your fasting glucose divided by 22.5 or something like that. The gold standards is something called a euglycemic clamp. This is like you take somebody who's not currently diabetic, but you're trying to find out if they have some insulin resistance. And you do this very invasive test, and no one recommends it, but that is the gold standard. It is called a euglycemic clamp. And all of these tests are trying to test if somebody is not yet diabetic. They're euglycemic, which means their sugars are normal. Eu just means normal in medical terms. They're euglycemic, and we're trying to just find out maybe years before if they are going to develop insulin resistance or have the genes for it or whatever it is. Now, in the future, maybe there's going to be some genetic testing you could do or some mRNA silencing, little, things that we can do to maybe knock out those genes like we do with inclisiran. Inclisiran is a PCSK9 medication that is a mRNA silencing gene. It's called CRISPR technology. You inject yourself twice a year. This stuff goes into your liver, knocks out the gene for PCSK9, and all of a sudden you have a PCSK9 loss of function mutation, which are like these people walking around with an LDL of like 10 or 15 that never have heart disease and could live to 100 potentially if nothing else goes wrong. So technology is getting better, and I don't think we need to get that fancy with the NMR lipoprotein IRs. I think we have more than enough information. Most people are euglycemic and have no insulin resistance genetics. If you check a fasting glucose on them, it's going to be like 70 something, maybe even a little less. Once you start getting over 80 and over 90, they have it. I mean, it's not rocket science. And same thing with A1C. Like the guy, I've done a bunch of videos on YouTube, comparing these carnivore guys, Dr. Berry, the carnivore butter steak gal, whatever her name was. They have A1Cs of like 5.5, 5.6, 5.7, 5.8. You're diabetic. I mean, they're all not diabetic at all. Like, yes, you are. 5.7 is literally the definition of diabetes in the United States. And so if somebody's like 5.5, 5.6, technically they're not quote unquote pre-diabetic, but they are. They have insulin resistance. Nobody would be even that close if they, had that. If you're below 5, below 5.1, you're probably okay. But it's something we can track and measure earlier and see if you're starting to go up. If you're going up, a little weight loss would help. Changing your diet around, getting to a calorie deficit of any kind would definitely help. And those would be some things that we would recommend if somebody is not even yet pre-diabetic, but they're starting to head there. Diet, calorie deficit, weight loss, and build some muscle definitely would help.
Wonderful stuff. And just so you guys know, I've talked about saturated fat before, but saturated fat it's pretty nasty, guys. Not only is it a tribute to plaque buildup, we have studies that show that it causes insulin resistance, fatty liver disease. So be very mindful of your saturated fat. And that's one good pro from Dr. Hello. Just calorie for
calorie. If you're in a calorie surplus and you're eating too much, calorie for calorie, when they've done substitution studies, saturated fat increases fatty liver disease 70% more than if it was a carb or a protein. And like I said, now we have a study that was published where they had 32 years of data, and they looked at saturated fat intake, but they used food logs, not just recall. Like people are like, oh, we don't trust these food frequency questionnaire studies. It wasn't just a food frequency questionnaire. They actually compared it to their food logs and verified they were actually eating what they said they were eating.
Right.
So it wasn't like, oh yeah, 30 years ago, this is what I used to eat. No, it was like every year, every 6 months, they would sit down with them, ask them, what did you eat this last week? And then, what do you remember eating this last week? And then they'd have them keep a food log throughout the time with it when they would check in with them to see if they're really eating what they said they were eating. and they found out, I think it was like a 60% increase in the incidence of type 2 diabetes in unprocessed, in processed meat eaters, and I think it was like 41 or 51, something like that. I don't remember. It's in the book. In people who ate unprocessed red meats. So regardless, there's a direct link, and they know the mechanisms. They know that, but that's not even the first study. That was the one that was just released in 24, late 23 from Harvard. We got tons of studies from before, but this one came out. It was the best done one so far because they had food logs, they had corroborating data, they figured out the mechanism. Previously, it was like maybe it was an association. It just happens to be that people who ate red meat, like let's say they eat a lot of cheeseburgers and are overweight and whatever. And even though they can correct for all that in the studies, it's not that hard to do. People say, well, they also smoke and drink. Well, we can correct for that. Like it's not rocket science. But either way, they thought initially maybe it wasn't directly linked or just a strong association, but now they found there's like a direct link between saturated fat intake, insulin, and salt, the two most pro-inflammatory substances you can consume are salt and saturated fat, the two S's. But those are two things that we try in heart disease to tell people to eat less of. Now, I'm not telling you got to be an angel. Like, I eat red meat every once in a while, but I'm not going to deny the science. I'm not going to say it's totally fine. It's not. But if you want to eat a ribeye here and there, some filet here and there, no big deal. As long as the totality of your diet is generally healthy, you can veer off a little bit and be fine. Also, like my LDL and ApoB are like 41 and 42. So I have a little more leeway. Not that I'm like going out and abusing it, but generally speaking, if you eat the way you eat and we check your numbers and they're fine, you're probably doing it right. It's not that big of a deal. So just make sure that however you eat, as long as you're being followed and your numbers are being, treated and tested, that if it's matching up with what we'd like to see, then you're probably okay.
Perfect. So two more quick things on ApoB, and I want to switch gears. So this is another one that you see a lot of mixed data, and I think you actually just posted about this with the egg. So is it fair to say that dietary cholesterol doesn't matter for most people in terms of the ApoB that we've been talking about?
So it kind of depends. Of course, like everything depends. I can't give a straight answer.
Right,
but
right.
And I think that's one way to know if someone's an actual real expert in their field is if I just said yes or no, then this guy's just crazy. He has an answer for everything. But it really depends. So there's 20% of the population are hyperabsorbers of sterols, whether they're plant sterols or cholesterol. Those people consuming more cholesterol is going to be an issue. The other 80% of people, it's not generally an issue except at extremes of intake. If you look at like the chart, which is also a nice graphic in the book, over about 400 milligrams per day, cardiovascular mortality starts to go up, especially as you get close to 1,000, and all-cause mortality, CVD mortality and cardiovascular mortality, CVD, cardiovascular mortality, and all-cause mortality both start to increase, almost doubling and tripling as you go over 400 milligrams and closer to 1,000 milligrams a day of cholesterol. Now, the vast majority of Americans don't eat that much cholesterol.
For our audience, what does that equate? So how many eggs would that equate?
An egg is about 187 milligrams. You'd have to eat, I don't know, 3 or 4 a day, maybe, something like that. But also, like, it would have to be on a long enough time horizon. It can't be like I ate 3-4 eggs one day and didn't eat it again for a month. Like, that's nonsense. That doesn't make a difference at all. But if you eat, like, let's say some of these carnivore guys and, some of these people are like, I eat 6 eggs a day. That's probably going to do it, and especially if you're a hyperabsorber. If you're a hyperabsorber, it's even worse. That would be really bad. Shrimp and octopus, I don't know. Americans do eat shrimp. I don't know about all the other stuff that contains cholesterol. But generally, eggs and shrimp are going to be like the top 2 in the United States that people would eat as just cholesterol. The issue with eggs, it's a little bit confounding because it contains saturated fat too, the yolk. So it's a little trickier to just isolate the cholesterol part of it. Shrimp is usually a pretty clean protein. You get a lot of protein for not that many calories, so I do eat them. But again, like I said, my LDL is like 40. But generally speaking, most people, dietary cholesterol, not going to be a major player unless it's at extremes of intake. If you're a hyperabsorber, it's definitely going to be a problem.
Okay. And then I'm assuming, do you check those phytosterol levels, cytosterol and camposterol occasionally if you need to?
I generally don't. You could do the cholesterol balance test. It's actually a mail away lab. You just prick your finger and touch a thing and send it away. Boston Heart Lab does it. I don't check it. I usually put most people on a low dose statin plus Zetia. Zetia blocks absorption,
right,
and statins block synthesis. Now, they each block a little bit of the other one too, but generally Zetia blocks absorption, and most statins generally block mostly synthesis. If you put people on a low dose of both, you get a much bigger effect than putting people on a whopping dose of a statin only or just Zetia by itself. Because what happens if you put somebody on just Zetia and you block absorption a little, there may be a slight compensatory increase in synthesis. You're still going to have overall lower LDL, but why not block both and get a much more profound effect? Same thing with synthesis. If you put somebody on like low dose Crestor, they drop their LDL by 35%, you're going to get a slight increase, in absorption of sterols in your intestines. So, I usually put people on like 10 and 10. I mean, it depends on where their LDL is. Sometimes I would be more, I'd give them more Crestor. But a normal person, let's say their LDL is like 130, 120 to 130. I'd probably put them on 10 of Crestor, 10 of Zetia. That'll probably get them into the 65 to 75 range. And that's probably good enough for most healthy people. Unless you just want to really be low, then we could probably do a little bit more than that. But no, I don't check the balance test at all. I don't find value in it because I think you should be on both anyways.
I guess that brings up my last question to round this off with ApoB. So what do you consider to be an optimal ApoB level with someone who is normal and healthy, not someone that we already know has cardiovascular disease? So a lot of the listeners out there, they want to know what should be my target ApoB level, and then to follow that up, at what point after we've done lifestyle optimization would you suggest doing a pharmaceutical intervention to lower it? So
I'll break it down the way you mentioned. So all comers, healthy people with nothing else going on, we usually want your LDL or ApoB even under 100. If you have one risk factor, and that could be a male over 45, female over 55, hypertension, obesity, diabetes, any family history of cardiovascular disease, if you have any risk factor, we want you under 70 usually on both LDL and ApoB. If you've had a ischemic event, let's say you have one stent, or you've had a stroke or a heart attack or had open heart surgery or anything, we generally want them under 55. And if you're having multiple events, we usually want you under 40. Or if you have lipoprotein A, we want you under 40. So let's say we'll take the first group that is 100. We want you under 100. If we took that group and they did everything right, they cut out saturated fat, they exercise, they don't smoke, they got everything under control that they can, that they can do, and their LDL is still like, let's say 110, 105, a low dose Crestor, like just 5 milligrams, can lower your LDL anywhere from 35% to 55, depending on the person. And some people 65, it just kind of depends. But that'd probably knock you into the 70 range, somewhere in that range, and that's probably fine for most people, assuming you don't have any risk factors or anything else. If you want to be like ultra, optimal, I would add Zetia too, just because it blocks absorption. If you happen to be a hyperabsorber, that would just give you a little bit more, reduction, an additional 15 to 25% reduction on top of what the statin would have done by itself. That's generally where we would start with a young, healthy person that's done everything right and couldn't get lower with just diet, lifestyle interventions.
Okay. I guess just kind of round this off. I'm seeing in a lot of the comments here, and I think now maybe because there's huge political movements, but this has been going around for a while. There's this medication phobia out there, and I'd like to just kind of talk about this a little bit and setting the record straight. I'm not a pill pusher, but I do think that modern medicine has its place. Pharmaceuticals definitely have their place, especially whenever you have focused on lifestyle optimization and you haven't gotten to where you need to go. So you kind of touched on which agents you use to help manage your LDL cholesterol and ApoB. And the topic of statins, it's controversial. I understand why some of the reasons. Maybe you can just you've probably done this speech a million times, but just explain to everyone just in common terms, why is there this backlash? Why is there hesitation to take them? And maybe you can kind of clarify some things behind what's going on with that situation.
So I think there's a number of different issues. First of all, people just don't want to take medications, which is completely understandable. I don't want to take medications either. But not all things are solved by just diet and exercise. Like I told you, I'm a certified personal trainer. I literally lift weights and deadlift and squat and bench press pretty much every day of my life. My LDL untreated is like 126. And I was smart enough to know that that's insane. And no matter what I did, I eat a clean, healthy diet, no saturated fat almost ever. So there's just no way that was going to come down. And the only way it could get it down is by taking Crestor and Zetia. Now, there are side effects. Like, people are like, well, you don't ever tell people about the side effects. No, we do. We can't, like, shove pills in your mouth. But there are side effects. They're not, very severe. But the thing that statins, the biggest side effect that we see in statin medications usually is like muscle achiness. And a lot of times it's people know that that's a side effect, so they start experiencing it. They call that the nocebo effect or the drucebo effect. You might get muscle aches, so all of a sudden you start having muscle aches. It's almost like a kind of a placebo effect, where they've taken patients, they've done studies where they've taken patients, not told them what they're getting, and told them that, this thing you're getting might cause muscle aches or might cause headaches or might get whatever. And they start experiencing those muscle aches, headaches, diarrhea, constipation, whatever it might be, and they weren't receiving anything. They were receiving a nonsense, nothing in it, pill of nothing. So I get that. I think a lot of it is this media frenzy. And the thing is with statins, they're super safe and effective, and they have, like I said, almost no side effects. Literally less than 3% of people have a real side effect, and they're not irreversible. If you get a side effect, we can stop the medication. We can pick something else. We have way more options now than we did before. We have statins, obviously. We have the Zetia. We have PCSK9 inhibitors. We have bempedoic acid. We have inclisiran. I mean, we have a lot of different options now with a very clean side effect profile. Like PCSK9 inhibitors, for example, the only side effect is, since it's an injection, it might hurt where you injected your skin. Literally, that's the one listed side effect, is that you might hurt, the skin irritation where you poked yourself with the needle. But otherwise, there's no side effects. So I think that's part of it, that it is a real concern. People may get side effects. But a lot of it, I think, is overhyped stuff in the media by these accounts and these people that have a lot to gain by telling you, well, don't take statins, but take my unproven supplements. A lot of people are just supplement salespeople, and they're just trying to sell you a bunch of nonsense that just does not work. They've tested all the weird supplements, the heart this and the heart that, and the cholesterol and the magnesium, niacin, CoQ10, fish oil, all this nonsense. They've tested it. It does not lower your cholesterol more than placebo. Like there was a study recently published by the Cleveland Clinic called the SPORT trial, where they looked at garlic, CoQ10, fish oil, turmeric, cinnamon, a couple other things that, I forget the other. There was 6 different supplements and a placebo, which was nothing, and Crestor 5, the lowest possible, dose of Crestor you could imagine. None of them beat placebo. The Crestor obviously crushed people's LDLs. The lowest, you had up to a 55% reduction in some people. Some of them actually increased inflammation. Cinnamon increased inflammation, as measured by high sensitivity CRP. Some of them actually raised LDL. I forget which ones it was. I don't remember if it was the garlic maybe or one of them. But definitely, all of these things, like I think a lot of people think it's not natural to take medications, and they don't want to take medications because they're not natural. Well, let me tell you, where do you think statins came from? They're natural. They came from fungus, just like penicillin. Like the most common, I tell you, most cardiac medications came from nature. Where do you think lisinopril comes from? Lisinopril, the most common blood pressure medication that we prescribe, is viper venom. It's literally viper venom. obviously it's not actual viper venom. We found the molecule in viper venom, and that's what we purified and controlled it so you don't get a whopping deadly dose. Where do you think metformin comes from? Metformin is the number one prescribed diabetes medication in the world. It costs zero. It's like cost pennies like statins nowadays. We're like, well, you're just making money off statins. No, you're not. They cost like zero. It's like 2 cents for a month supply of almost any statin, other than pitavastatin, which isn't generic yet, but nobody uses it. But metformin came from the French lilac plant. Coumadin, which is a blood thinner, is sweet clover. It's literally actual sweet clover. The digoxin plant, or the digoxin drug, comes from the foxglove plant. They noticed that when people would make salads out of foxglove leaves, they would go into heart block and be lethargic and weak for like a few hours. So, most of these medications, there's a natural fallacy where natural stuff has to be better than actual pharmaceuticals, which is not true at all, obviously. There's plenty of natural things that can kill you even, like, arsenic, which is available in almost every pit of like peaches and apricots and apple, seeds or whatever. But that doesn't make it, the dose makes the poison. If you swallow an apple seed or eat a little bit of apricot and swallow the seed by accident, nothing bad's going to happen. But at a high enough dose, obviously arsenic is very dangerous. So I think part of it is people don't want to believe. There's this mistrust of medicine and pharmaceuticals. What they don't realize is that the supplement industry, first of all, they're all owned by the pharmaceutical companies. Like Pfizer owns Nature's Made, Novartis, and all these other companies. They all own the pharmaceutical companies. So people are thinking, well, I'm not going to give my money to big pharma, but you are. You're buying unproven supplements that literally have no regulation. They don't even contain what you say they contain. Like even fish oil, the simplest thing to make would be fish oil. They did a study. It was published in New England Journal. I can send it to you if you'd like. They tested 3,000 different fish oil supplements in the United States. 95% of them did not contain fish oil. So like you're buying a bunch of nonsense that contains almost nothing. Turmeric, for example, did not contain turmeric. It turned out to be like orange powder, and some of it turned out to be liver toxic. I mean, they're buying all this stuff that has nothing in it, and the supplement industry loves it because they're not tested. They don't have to answer to anyone.
Right.
The FDA doesn't care. They just call it a food product, and you could put anything you want on the label. You can say it supports food, supports heart health, supports bone health, supports inflammation, and all these things turn out to be nonsense because I tell people, like, if these things work, they would actually be a medication. Don't you think Pfizer is looking for the next big inflammation reducer, gut microbiome saver? Like, don't you think that would be the next billion-dollar drug if it actually worked? Like, where is this? I would want to do that. Like, they noticed that fungus improves cholesterol, and they figured out the molecule in the yeast that does it, and they made statins. Levocor, pravastatin and lovastatin were the first two. Anytime we notice something works, it becomes patented as the next billion-dollar drug. People are like, well, you can't patent nature. That's why you guys don't make it. Like, yes, you can. Literally every drug I just mentioned comes from nature. Do you know where Ozempic and Mounjaro come from? Like all these new GLP-1 weight loss drugs? They come from the saliva of a lizard in Arizona called the Gila monster. It's the only venomous lizard in the United States. They found a little molecule called GLP-1 that makes you feel fuller, longer, slows down gut mobility, increases a little bit of insulin secretion, does all kinds of things, and it causes a tremendous amount of weight loss, improves people's A1Cs and diabetes control. It is a molecule that is found in humans too, but this one has a much longer half-life. Our own GLP only lasts a few minutes, whereas these GLPs, the original ones, lasted a day or two. Now they last up to a week, and they're working on some that will last even longer. But these are like life-altering medications, and why not use them? They were discovered in nature, so I don't understand some of that a whole lot.
It's definitely a thing.
I mean, like water can kill you. I'm sure you've had hypopotonemia or whatever, the people that come in that drank too much water too quickly, you have seizures and die.
Yeah.
I mean, that's natural. Why are we not recommending people drink 2 gallons of water in 5 minutes? Like, they will die, I think people that are non-medical, I think part of it is people like to believe in conspiracies because they want to believe a stronger power is keeping them unhealthy. Well, it's not my fault. It's the government's fault. It's big pharma. It's this. No, it's a lot of it is you, and we're trying to help you, but you got to see us and do what we say. And I don't know. I feel it's a complicated answer that we could probably do 3 hours of about just that, because there's a lot of interplay between socioeconomic stuff, mental, psychological stuff, and distrust of government and, medicine and doctors and, all that kind of stuff where people are looking for a hero to save them. And here come these heroes of anti-pharmaceuticals and anti-medicine, anti-Western medicine heroes. And, it's a lot of things that I don't know that will solve that in one sitting.
I think the one thing that I do want to hit home with you, because you have so much experience with this and some of the roadblocks that I faced in my preventative medicine practice is, specifically with statins. And I know there are a ton of other agents out there and other agents that are much more aggressive in lowering ApoB and don't come with some of the possible side effects, which are minimal in statins, but they're not covered first line by insurance. So
you're not going to get Repatha or bempedoic acid or any of those covered. Zetia is generic. You can. So are almost all statins, and they're the most effective. They have the most data. We have 20 to 30 year data now on statins. The WASCOPS, West of Scotland, whatever trial has 20-year data now on the statin that they had put them on. Even when they were on it for just 5 years, 20 years later, they have lower incidence of heart disease by a lot. And the absolute risk values, people always make fun of us because they say, well, you guys always report the relative risk because they're higher. Well, then use the absolutes if you want. What's the big deal? It's just statistics. But the absolute risk reduction in some of those trials, and that trial specifically was like a 6% reduction in almost all endpoints, which is way more than these people. And if you looked at like the relative risk, it's almost like a 90% reduction.
Can you explain that to our audience? Because most people don't have any type of science background and they don't know how to read studies. And I get a lot of people that they say this blanket statement that statins don't decrease mortality, they don't decrease cardiovascular risk, and you see the headlines, but people, number one, don't understand the difference between absolute and relative risk. And that's very important to understand that, especially whenever we're looking at statins, which are in trials over just a couple of years, right? And we're talking about something that takes decades to progress. So the fact that you're actually seeing improvement over a study is actually very, very, very significant. So can you just kind of tee it off to you?
Yeah, so the absolute risk reduction is the exact percentage. So let's say you take two groups of people, 10 people in each group. One group gets a statin, one group gets a placebo. One person dies in the, all 10 survive in the statin group, but one person dies in the group that didn't get any medication. So you have one less person. That goes from 10 to 9. Technically, that's a 10% reduction, relatively speaking. Going from 10 to 9 is a 10% reduction, but it only is in absolute risk. Their risk, let's say, of dying was, that's not a good example. Let me think of it in a better way. So let's say we take 100 total people. This will be easier to understand. If we took 100 total people on each side and we put one group on treatment and one group not. The group on treatment, let's say they all survived, nobody died. The group that didn't get anything, let's say 10 of them died. So you had a 10% absolute risk drop, right? You had 100 people, now only 90 survived. That's a 10% reduction. That's a 10% absolute reduction. But because nobody died in the other arm, 100% of them survived, you almost have like an infinite relative risk reduction. Let's say only one person died, instead of 100, 99 survived. 1% versus 10% is a 90% reduction in relative risk. The 10 people died here, like the 10%, 10% of the people died versus only 1% of the people died. It's a 90% relative risk reduction. The problem, like you said, with some of these people, they want to say, well, you guys always report the relative risk because they're so huge. Let's say in the case of like the Jupiter trial, and I'm just making this up. Let's just make up a trial. You put people on aspirin, and you have a stroke rate of 2%. Only 2% of people on aspirin get strokes. You put people on nothing, and 3% of them have strokes. It's slightly higher. It's a 1% absolute risk reduction from 3% to 2%, but it's 33% relative risk reduction because 2 out of 3 is 33%. So people say, well, you guys only report the 33% because it's so high and it sounds amazing, when literally it's just 1%, absolute risk reduction, which is absolutely true. But now multiply that by 9 billion people on Earth. That's like 30 million lives saved, maybe, or 90 million. I don't know what it is. Some crazy high number of lives saved when you multiply it out. And also, like you said, as time goes on, the area under the curve increases exponentially.
Right.
Eventually, the absolute risk dwarfs the relative risk. Eventually, if you carry it out on a long enough time horizon, the person was on a statin for 13 months and they had a 1% relative risk reduction. Now, carry that over decades, it's going to be an enormous amount of risk reduction and lives saved multiplied by 9 billion people on Earth. So I think people don't understand those type of statistics, and they just hear, well, statins only add 4 days to your life. Even the people that published that study, and I have a huge long blog article on that, and it's actually a whole chapter in the book. The guys who published that study said we were thinking of not publishing it because it's insane. It makes no sense because we only looked at studies for a year and a half, 3 years, 4 years. Of course, it's only going to add like 7.25 days or 4.25 days to your life. But if you carry it out mathematically and project it over, decades, obviously you would add, decades to your life. Before statins, people would go to the hospital with a heart attack, they'd get some oxygen, get a little bit of morphine to feel better, and you'd hope they'd be alive by the next morning. 80% of them would be dead. This is 1958. 80% would be dead by the morning. Now you have a heart attack, you go to the hospital, you might get a stent, you might not, you might get blood thinners, you get heparin, you get Lovenox, aspirin, Brilinta, whatever, statins immediately. Now you have like a 90% survival rate. The only ones that like die from a heart attack are the ones that had way more comorbid conditions and, smoked their entire lives on top of it and had all kinds of stuff. Now, of course, there's some weird genetics sometimes, but the vast majority fall into that category. So you're getting an 80 to 90% reduction in death rates compared to what we had before. And they estimate that statins have saved, probably millions, if not billions of lives now since being introduced in 1987. And then don't forget, in some of those studies in 1987, the original 3 statins were weak. They were not as potent as like the Lipids and the Crestors now, and Zocor even. But they were like the lovastatin, the pravastatin, much weaker statins, the original trials. And even then, they showed tremendous benefit. So I think you have to just have a conversation with your patients, be like, listen, these medications have been around forever, and they're the most studied. They're cheaper than dirt. If you have a side effect, we can stop it. We can pick a different one. That's what I tell my patients. Usually, my patients don't argue with me a lot because they've already had a heart attack or stroke. But yours, that are coming in that are, I just want to prevent a heart attack or stroke, family practice, primary care, preventative type stuff. In your scenario, you'd say, listen, these medications have been proven to save lives, prolong lives, improve your health span because you live longer without heart attack, without strokes. Like, what's the point of living to 100 if the last 30 years they're in a nursing home with other people cleaning you and feeding you and all of that? So if they want to, and if they get a side effect, like, listen, you're not getting married to this drug. You can switch to another one. It's not that big of a deal. There's no irreversible side effects from any of these medications. So if somebody's arguing that I don't want to take a statin because, I heard that you might get a muscle ache or two, not true. If they say, well, I heard you might get dementia, that's actually not true either. Dementia now, the number one risk factor for dementia is high LDL cholesterol. This was just published in The Lancet in 2024. That's in the book too. That I had to add that chapter because it was literally just published like a month before the book went to press. But even then, we still had studies from before that showed that all comers, with 7 million person years of follow-up, huge trials, with 7 million person years of follow-up, you had a 20% reduction in dementia and a 32% reduction in Alzheimer's in people that were on statins. So people say, well, if you take statins, you get dementia. That is not actually true at all. It actually reduces dementia. So we highly recommend that as a preventative, for dementia, that people be on statin medications or LDL lowering medications of any kind. And there are all kinds now. You're not just stuck with statins. Those are going to be your first line because they've been around the longest. They have the most data behind them. The PCSK9s are newer. Bempedoic acid is even newer than that. Zetia has been around longer, and that's how it's generic and cheap. But Zetia plus statin usually is the first line to go to. Somebody's saying wonderful information. Does being on a statin cause a higher calcium score? Should we take questions from the crowd?
Yeah, go.
Do you have any on your end?
Let's do it.
So
Yeah.
somebody's asking, does being on a statin cause higher calcium scores? There were studies in the past that showed that, and now it shows it has almost no effect. But either way, like just using the model to explain this, if you have plaque, like this, calcium usually means you have like end-stage plaque, which is over here. When you have end-stage plaque, and you start taking a statin and lowering your LDL, it remodels the plaque. It develops a fibrous cap. Some of it may calcify, but it makes it more stable. There are vulnerable soft plaques that may harden a little bit, and so they're no longer likely to rupture. And so that's why we put people on statin medications or lipid-lowering therapy to stabilize soft plaques. 80% to 90%, 85 to 95% of acute MIs or heart attacks are a soft plaque rupture. They're not the old calcified arteries that are slowly getting, narrower and narrower and narrower. They're like these acute ruptures. Boom, a soft plaque ruptures that might only be a 20% blockage. It ruptures, goes downstream, plugs up your arteries, and that's how you have a heart attack. So those are the ones that we want to eventually develop a fibrous cap and become harder and more, thicker. They don't necessarily calcify. They might if they were on the brink of calcifying. That may happen. But generally, in the past, statin studies have shown a little bit of an increase in calcium score, but the most recent studies with better imaging and higher resolution imaging have not shown increases in calcium scores. Somebody said cayenne pepper is not evidence-based medicine. That is correct. I don't know what you would use it for other than burning your throat and mouth.
Real quick on that, just to finish off with the testing, I'm curious on your take on this. So I'm reading more and more that the calcium score is just not as reliable. Obviously, in certain patient populations, it's good. But what is your take on the Clearly scan, the coronary computed tomography angiography? Are you using that in your practice now for prevention?
I read all of these tests, but I don't order them. The problem with the CCTAs is very similar. You're looking in the lumen. So just for people to understand what we mean, the dye goes through here, right? You cannot see this stuff that's in here that the dye isn't being plugged up. Now, once it gets bad enough where it looks like this, like if you see my finger can slide all the way through here, but once it gets to this part where it's bad, then it's plugged up enough where the dye won't go through. You see a little narrowing right here, kind of like how it narrows down a little bit. That's when it would show up on a CCTA, which is also like pretty end stage. If once it's encroaching on the lumen, you got this wide open lumen. Once the plugged up area is encroaching on the lumen, you're kind of towards the later stages of atherosclerosis. We don't want to wait for that. So me personally, I would never order those studies. I do read them. I mean, it's my job. And it clearly has like AI and it's supposed to be a little better. The problem with the CCTAs, and if you work with them in emergency medicine, you probably look at these kind of scans, especially for PE and whatnot. There's a lot of what they call it misregistration artifact, where if you don't get the timing of the dye exactly right and the heart rate's not slow enough, you're trying to freeze frame a moving heart, you're trying to freeze frame a moving object and computer regenerate the images of the dye flowing precisely through the artery at the exact amount of time, which is not that easy. You get a lot of these motion artifacts, misregistration artifact. In cardiology, especially when you're injecting a coronary artery, you get this flow. I forget the name of that artifact. It'll come to me. But your flow is not exactly perfect through the artery, and if it's not being injected at exactly the right pressure or exactly the right timing, and there's a poor flow, or no reflow, whatever you want to call it, you end up getting blockages that don't actually exist. You're not getting a real accurate picture. So to me, they're useful. Like, if you think somebody has a PE or something like that, by all means, you got to do something, or an aortic dissection, whatever. Those you definitely wouldn't miss with the CCTA. I mean, you still could. I'm sure there's a error rate, but the Clearly, I think, is a little bit more gimmicky. It's a little AI, and supposedly they see plaque in the walls and all that. I mean, it doesn't, but it's cute. So I don't know that I would, hang my hat on that at all. You generally don't want to check a calcium score in somebody under the age of 40 because they won't have calcium.
Right.
Until they're much older, so it's kind of useless. I don't check calciums anyways. For me, like as a preventive cardiologist, the cutoff is 60. Every trial that's ever been done, if your LDL is below 57 milligrams per deciliter, you don't have atherosclerosis. If it's above, it starts happening. How much above? The higher, the worse. So we know in the most recent Michael Shapiro studies, which are obvious, everything I'm telling you is in the book with like cool diagrams, all the pictures, everything. But the Michael Shapiro study that looked at milligram years, they looked at what total number of milligrams of cholesterol over what number of years do people finally start to get plaque. So the number was 5,000. So if you take your age times your LDL cholesterol and it's over 5,000, you have plaque. So a 40-year-old with an LDL of 125 has plaque. That's exactly 5,000. 40 years old, 125, that's 5,000. You have plaque. Below 2,000, we know you probably don't have plaque. Between that 2 to 3 to 4 range, you have some plaque. It's just not like as bad as the 5,000 and up. Now, if you're 10,000, 8,000, all that, yeah, you have a lot of plaque. But if you just want to go by your LDL number by itself, below 57, below like 60 milligrams per deciliter, you probably don't have plaque. It's almost impossible to create plaque at that level. And if you're above that, you have varying degrees of soft plaque, depending on how long you've had high cholesterol for. So that's kind of how we look at it. And as a preventive cardiologist, I don't want to ever have to deal with it. If I can get your cholesterol under 60, your LDL under 60, then we don't have to worry about this problem. You can go worry about other stuff. That would be my target for most people. Now, if you have multiple risk factors and you've already had issues, then no, we want it way, way, way lower. The lowest we'd want is somewhere in the 20s to 30s if somebody has lipoprotein A, which we haven't really talked about, but somebody has to question. So this is a normal low-density lipoprotein. There's a thing called a kringle that goes around it. It's a genetic thing. 25% of people actually have this, but we only check about 0.1% of people, which is really weird. But this makes your LDL particles 3 to 6 times more atherogenic than normal LDL particles. So I check on everyone an ApoB and a lipoprotein A. They're both technically apolipoproteins, so if you type in lipoprotein A or lipoprotein B, it should come up in your EMR as a lab test. But that makes your cholesterol way more atherogenic and should be checked on everyone at least once in a lifetime because we have no way of lowering it currently. There's 4 or 5 medications in the works that should come out soon, but it's going to be like 5 to 7 years before anybody can really be on it, realistically speaking. But if your LP(a) is high, you want your LDL below 40, and the lower below 40, probably the better.
So with the LP(a), I know checking it once in a lifetime because it doesn't vary much. In terms of lowering it, can you actually accelerate or can you create more particles by bad habits, or is it just kind of stay in a certain range?
It is an acute phase reactant, so it will fluctuate a little. But it's kind of like a calcium score. Some of my patients are like, well, my calcium score was 878 and I took cayenne pepper and now it's 785. Like, listen, man, your calcium score is still pretty insanely high. Like, you did not change it. You'd probably use a different scanner or there was a different scatter artifact this time. Like, it didn't change. Like, imagine you come to me one day and you're like, I have $812 in my bank account and tomorrow it's $852. Like, did you really become rich or anything? No, you still have about $800 sitting in your account. Think of a calcium score that way. Like if you're like, 1 year it's 112 and the next year it's 98, it really didn't change. There's scatter artifact. There's a million reasons why they vary. So same thing with lipoprotein A. It does vary a little bit. It's an acute phase reaction. If you're acutely ill, it does go up a little. If you're stable, not in a stressed out situation, you're not septic, you're not, having a lot of, weird stuff going on, it's probably going to be at its lowest. Which is when we recommend to check it. Check it when somebody's normal and healthy, just to get a baseline. You don't want to check it when somebody's acutely ill because it will definitely be higher. The only medications that we have now that can lower LPA are PCSK9 inhibitors. They're not approved for it and they're not indicated for it, but they do that. But those would be the only. But we do know, like, if you lower your LDL to below 40, we reduce your risk by like 90% anyway. So whether you have LPA, or not, but if you have LPA, it definitely needs to be much, much lower.
Okay. Before we go, you can answer a couple more questions at the very end, but I wanted to give you the opportunity to talk about your upcoming book, which I just purchased not too long ago. When we get it, when does it come out? When is it released?
No, it's on pre-order right now on
Okay.
Amazon. You can get it. You can order it. It should arrive November 20th. So I think right before Black Friday. This is what it looks like. It's just called Cholesterol Truths, and it's how to live your longest. Now, people are like, oh yeah, you're just a shill for big pharma. This is 516 pages. There's probably 4 pages on the actual medications that you can use. The rest of it is basically background information on what cholesterol is and what all that kind of stuff, and then basically lifestyle. Like, you want to learn how to live your longest without taking medications, this is your book. There is a small section on the 4 or 5 different therapeutics we could use. It's not that complicated, but there's like statins, there's bempedoic acid, there's Zetia, there's PCSK9s. Maybe I'm missing one, but that's about it. There's not really a whole lot of options. Now, people have super high lipoprotein A. I forgot to mention this. There's a thing called a lipoprotein apheresis that we can do. It's almost like a dialysis. You go to a center, they put a big tube in your vein, they suck out your blood, circulate it through a machine, take out all the lipoproteins and put it back in you. You do that a few times per year. Yeah, Andrew is saying peclosarin is a medication that will lower lipoprotein A. Yes, that one's almost approved. But like I said, usually when they approve these drugs, it'll be for the nightmare scenarios. It'll be for someone that's had open heart surgery with stents, multiple valves replaced, that those people get approved first. Kind of like PCSK9s, when they first came out, it was for the nightmare scenarios, and then finally 12 years later, the general public can be on them. But yeah, the book, I'm not really here to talk about the book, but yeah, you can order it on Amazon. Just type in cholesterol book or Dr. Allo cholesterol book, and you should find it pretty easily. And, I will mention, this is super cool. Dr. Dayspring helped me write the book. He's like the world's greatest lipidologist. He's given 5,000 lectures on the book. He included all those lectures in the book. On the first page, there's a code you can use. You get access to an online course through an app or through your browser, however you want to do it. You get access to an online course either through an app or a browser, where you could watch every single lecture he's ever given on cholesterol with all those like neat graphics and the cool animations, and he's talking over them, explaining how cholesterol is made and how it's metabolized and where it goes and how it's absorbed in the intestine. I'll show you like an example of one of his drawings. Your viewers may like this. Like, these are the kind of like drawings that he has in the book. We have these, the cholesterol, all the different pathways, and these are animated in the course. Like, when you get the course that comes with it, they're animated, they like move all around, and the lipoproteins go this way and that way. It's like, if you think these things are cool, just imagine these things like, going on a screen, on a video or whatever, along with the audio, taught by the world's greatest lipidologist. So I think people will definitely appreciate that. I know I appreciate him. He helped write the book and edit it. It's been a 2-year process going back and forth, millions of Word documents back and forth, and phone calls and video conferences and Zooms and all that. But it was a lot of fun. I made it for you guys. People were like, well, you should just write a textbook. How are we going to find all these videos? I'm like, just go on YouTube. There's videos. Like, no, we want like a textbook. I'm like, that's a lot of work, but I suppose we can make a textbook. So there it is. There's the cholesterol textbook that everybody's been asking for.
We really appreciate it. It's a lot of hard work, but for those of us that really want to learn and dive in deep, this is going to be really beneficial. So much appreciated for that.
Yeah, no problem. Somebody's asking, do the measurements in Canada are different than the United States? Yeah, they're in millimoles. You multiply by 38.6. So if I'm saying, so it's about 38, let's say. One millimole is 38, or let's say just 40. So an LDL of 1 in your Canadian or international units is 40 milligrams per deciliter American. So when we say somebody has lipoprotein A, and we want them under 40, we want them under 1, basically, or 1.1 in Canadian. If we say we want you under 80, that's like 2, basically, in Canadian, or, 38.6 times 2, whatever that, almost 80. So that's the conversion unit. I think Andrew was explaining that to somebody. Did you have any other questions? There's a few over here. Somebody thinks, can an angiogram see soft plaque? An angiogram can see soft plaque if it encroaches on the lumen. So I think Rosa was asking this. Like this soft plaque here, it's not going to see. This is where the dye goes. It'll never see this. Once it gets to here, it's actually plugging up and encroaching on the lumen. It's tightening it up. Then it'll see this, and it'll actually show up. But you don't want to wait that long. Like that's decades later. That's decades too late. You generally don't want to wait that long. Somebody's asking, is an HDL over 120 dangerous? HDL we used to think was protective. Generally, we don't follow it anymore. Over 120 is not dangerous. It could mean you have a hyperabsorption problem with cholesterol. It may mean your HDLs are dysfunctional because they're not doing their job. But either way, there's nothing to do. We just leave it alone. So I don't know that we would do anything for that. Did you have any questions on your end?
I don't have any more questions. I was just kind of sifting through here to see if there was anything else. There was one question here that asking about, we kind of touched on this. How do you know if you're a high absorber? And we had talked about the phytosterol test that you can order through Boston.
Yeah, Boston Heart Lab. You can actually go to their website, order it yourself. You prick your finger, put it on this piece of paper, and they'll tell you when you mail it back to them. Or your doctor has to order it. You generally don't need to do that. One way you can kind of test it yourself. Well, I don't know if you can test it yourself, but if somebody gives you a prescription for Zetia and your cholesterol really goes down way more than the expected 15 to 20%, then you probably were a hyperabsorber. If they give you Zetia and it just changes a little bit, just drops by 10 or 15%, then you're probably not really a hyperabsorber. You're just a normal absorber. I don't think it's necessary. I've never personally ordered those tests in treating my patients at all. Like I said, I just have a two-pronged approach. We treat synthesis and absorption at the same time. Somebody is asking, how do we find a preventive cardiologist in our area, which is in New York Metro, New Jersey, Westchester, Connecticut area? That I don't know. I'm sure you could easily Google preventative cardiologist, but just be careful. A lot of people that call themselves preventative cardiologists are just trying to sell you a bunch of nonsense supplements. I run into some of these people online. Make sure they're like an actual practicing cardiologist. Go to their website. If they have a bunch of supplements listed, just find somebody else. That's somebody just trying to sell you a weird dream and to profit off of you for no reason.
We got here, with 5 milligrams of rosuvastatin, I've had severe muscle cramps and pain. Which medicine should I go to now?
So there's a few options. One would be to just take the rosuvastatin once a week, because take 2 weeks off, take it just once a week. If that seems to work, you could also add do another day later, make it just Monday and Thursday, and if that works, that's fine. If not, they could try atorvastatin. They could try some of the older ones like pravastatin. No big deal. The next step would be to add Zetia to it. If let's say that the once a week rosuvastatin worked fine, there was a trial called the Chicago trial where they gave people rosuvastatin just once a week, and it did lower their LDL, mainly because it has the longest half-life of all the statins, but it worked. But you could add Zetia to it. Next would probably be a PCSK9 or bempedoic acid, whatever your insurance approves. Most likely it would be a PCSK9 because they approve that a lot easier. Somebody says, will the average layperson be able to understand everything in the book? Yeah, absolutely. This book is written for the lay people. Definitely doctors, I consider them lay people when it comes to lipids and cholesterol, because they have no idea either. So I wrote it with a general, 5th grade audience in mind. Now, chapter 9, which is mostly authored by Dr. Dayspring, you would probably be at a high school level to understand that one because it does get a little technical. That's the lipid absorption and metabolism chapter. But almost all the other chapters are very basic 5th grade to 6th grade English level material.
I know you've already touched on this, but someone's saying, according to studies I've read, statins do not prevent future heart attacks. I think we kind of already covered that.
Yeah, but that's a good question because a lot of people say that. They absolutely reduce not only future heart attacks, they also reduce strokes, peripheral artery disease. They actually reduce all-cause mortality. One of the biggest studies, people always complain, well, why don't you guys look at all-cause mortality since you can't fudge the numbers and you can't make it up. I don't know why they think we're making things up. But if you look at all-cause mortality, the largest study ever done looked at 26 statin trials. And there's only 6 statins. So there's 26 trials that are very famous on pretty much any statin you can imagine. And they did a forest plot where this side reduced all-cause mortality, this side did not. Literally every single one of those studies, depending on how potent the statin was and how much LDL cholesterol lowering you had, improved all-cause mortality. And I have those on my blog. If you go to drallo.net/blog, you can look at every study, and it's a live link. If I say a study looking at 26, it was a meta-analysis of 26 studies, they all showed a reduction in all-cause mortality, cardiovascular endpoint, cardiovascular mortality, blah, blah, blah. The live link to the study is there. You can go click on it. It takes you to the website of the actual study, and you can read it and analyze it and critique it. You can message me back. We'll have a good time discussing it. No problem. But definitely, first of all, the cardiovascular reductions were way more than the all-cause reduction.
Right.
Cardiovascular endpoints in most of these studies were decreased anywhere from, like, for example, 1 millimole reduction in LDL cholesterol, which is like 38.6 reduction in millimole in LDL cholesterol reduces cardiovascular risk by 26%. So if your LDL is like, let's say 140 and we drop it to 102, that's a 26% reduction. We drop it another 40 to 60, 63, whatever it ends up being, that's another 26% reduction. So for every 1 millimole reduction, this is for my Canadian audience, I guess, but for every 38.6 reduction in LDL cholesterol, you get a 26% reduction in cardiovascular risk, whether that's heart attacks, strokes, cardiovascular mortality, etc. Those are way higher and way more impressive than the all-cause mortality reductions. And even though we still had those, somebody's asking about Repatha, saying Repatha lowers LDL by 55, but no CRP reduction. Yeah, Repatha can crush your LDL, especially if you add it. If you add it to a statin plus Zetia, you can get like a 95% reduction in LDL cholesterol. Those are the nightmare scenarios with these people that have insanely high cholesterols, LDLs of like 300, 400, that we need to get them down into the 20s and 30s. Those would be the people that we'd add statin plus Zetia plus PCSK9 to get them, get a 90-ish% reduction in LDLs. Do GLP-1s reduce cholesterol? This is a very nuanced question also. If the GLP-1 medications like Ozempic and Mounjaro cause you to not eat saturated fat, then yes, that would reduce your cholesterol. But otherwise, just by themselves, maybe not. Maybe just if you're not, maybe because you're eating less total calories and some of it was saturated fat, sure, but it has to be with a reduction in saturated fat in order for that to work. Somebody said that I'm on statins now, my LDL is 60, which it used to be 110. That's fantastic. So you're doing a great job. I would probably stick with what you're doing because clearly it is working. Somebody said GLP-1s likely improve all metabolic markers. Yeah, absolutely, especially because the weight loss, the obesity in and of itself is very pro-inflammatory. So when you lose weight, your fatty liver goes down, all your cardiometabolic risk factors, CRP, inflammation, almost any way you measure it, homocysteine, uric acid. Not that I recommend people to check these things. It's just a bunch of nonsense for researchers. But definitely your A1C, your fasting glucose, all that stuff will definitely improve and go down.
Here's one more that's good that we didn't touch on with the statins. Statin drug unfortunately gets into all of your cells, can cause lots of side effects such as muscle pain, memory loss, insulin resistance, type 2 diabetes, vision problems.
Yeah, so this is a good question. We have touched on this earlier. Statins do get into all of your cells. They will reduce cholesterol synthesis in most cells, which is what you want, because cells make their own cholesterol. People say, well, why would you want to reduce your cholesterol? Because it kills you. But it does reduce cholesterol synthesis. Your cells can make cholesterol. They make all the cholesterol they need. It's when you have extra cholesterol floating in your circulatory system, in your bloodstream, that's a problem. So statins, PCSK9 inhibitors, all these other medications, they reduce cholesterol in circulation, which then reduces, excess cholesterol in circulation getting into your arterial walls and plugging up your arteries that feed your brain as well as your heart. And that's why dementia is caused by high cholesterol. People say, well, statins cause insulin resistance. They actually don't. If you are already insulin resistant, I actually just put a video on YouTube on this today. I literally just published it before we got on. But statins, if you already have insulin resistance and you're on a statin, in like the Jupiter trial, for example, people's A1C went from 5.7 to 5.8, which is a 0.1% increase in A1C. All the other trials have shown very similar things. That their most recent trial was 5.5 million people in it, veterans, 5.4 million veterans, where they showed a 7% increase in intensification of diabetes medications, but no new diabetics. No one that wasn't diabetic suddenly magically became diabetic. They're already diabetic. They got put on a statin. Now, we don't know if it's because, well, now I'm on a statin, I can eat whatever I want, and they start eating, worse and gain some weight and their insulin resistance gets worse, or it's the actual effect of the statin. They're working out the mechanisms now. There probably is a small effect in the statins because we even saw it in the Jupiter trial where people didn't even know what they were on. So there was a 0.1% increase in A1C, but no one who's not diabetic magically got diabetes. Now, there were people on the threshold of being diabetic. Let's say your A1C was 5.6, and now you're 5.7, or let's say you were 6.4, and now you're 6.5. That does, quote unquote, make you diabetic, but you were already pretty diabetic to begin with, just no one has told you yet. With regards to dementia and Alzheimer's, statins, people on statins have a 20% reduction in dementia incidence and a 32% reduction in Alzheimer's, so that is not true at all. Statins, unfortunately, get a bad rep. Do they cause muscle aches? That part is generally true. In about 1 to 3% of people in most studies may complain of some muscle aches or myalgias. We call them myalgias. But stopping the statin instantly reverses it. And picking a different statin, usually they don't get it. Just kind of depends on the person. But if it becomes an issue and it's intolerable, you could take the statin just once a week. And we can add Zetia or other medications, bempedoic acid, and or PCSK9s. The nice thing about bempedoic acid is that it works on step 3 of the cholesterol synthesis pathway in the liver, as opposed to, I think, step 5, which is HMG-CoA reductase. Bempedoic acid is very liver specific. It does not reduce synthesis of cholesterol other than in the liver, which is why it's not as potent as statins, but still, you could see anywhere, it's kind of like Zetia. You get a 15 to maybe 25-ish % reduction in LDL cholesterol, depending on the person. Now, obviously, if you put Zetia with it, it increases it. It's a little more synergistic. It's a little bit hard to get approved just yet for most people because there are generic alternatives that are super cheap. But I think going forward, as the guidelines kind of catch up and we move bempedoic acid up a little, it'll become cheaper and cheaper.
Excellent.
So somebody's asking, my ApoB and LDL cholesterol are both in the 50s. ApoA is less than 6, managed well. So you don't need to check ApoA. ApoA1 is a HDL marker. The problem with, let's say this is an HDL, the problem is ApoA, let's say it's this blue thing. You could have 3 of them. You could have 1 of them. You can have up to 5 on one HDL molecule. So it's not a good way of measuring or tracking HDL. So we don't generally recommend checking ApoA. She means A1, I'm assuming. But checking ApoA1 is not helpful unless you mean apolipoprotein little a. If you're talking about apolipoprotein little a, which unfortunately the terminology or the way she typed it, it's hard to tell. But if you're talking about lipoprotein little a is less than 6, then you're totally fine. That is your highly atherogenic lipoprotein A, the small a. You typed it as a big A, so I don't know. But if you mean little a, then that's fantastic. You want it that low. You want your LDL and ApoB below 55, which yours are. So you'll do really well. She says, knowing minimal calcium in descending aorta for a 50-year-old male. Yeah, so the lower, in your case, the lower the LDL, the better. 50 or under is probably fine in that person's case, with and depending on where it started, but in that case, it's probably fine. Did you mention pitavastatin? I did not, because it's not generic and there's nobody going to prescribe it. It is potent. It has the same potency as pravastatin. The weakest statin was probably pravastatin, then lovastatin. Simvastatin's in there. Pravastatin probably second. So pitavastatin is somewhere in there. It is synthetic. So it is the latest statin that was invented. Crestor is still the most potent. It would be like Crestor, atorvastatin, Zocor, which is not synthetic. It's basically, the older non-synthetic ones. Then I would say maybe pitavastatin and pravastatin together. And then lovastatin probably in that same lower end group there too. Dr. Allo is misinformed. Bempedoic acid is now easier for insurance to cover than PCSK9 injection. Well, that would be great. That would be fantastic. That would be good. That would be good to know. Depending on the patient's insurance plans, obviously. How soon can you retest LDL after making dietary improvements? So this is a good question, actually. If you change your diet, because it affects the saturated fat, affects LDL receptors and signaling, it would take 3 months before you would notice an appreciable difference. Can you notice something within 2 weeks? Yes, absolutely. In some people, in 2 weeks is more than enough. But most people, to get a realistic idea of how much diet affected it, you'd have to look at a 3-month window. With medications, though, it's like instantaneous, especially statins. Statins and Zetia, put somebody on Crestor tonight, tomorrow morning their LDL will be like 50% lower than what it was today. So with Crestor, I usually tell them if we add Crestor or up the dose or whatever, just go get it checked tomorrow or the next day or within a week. It's not a big deal at all. Thank you for educating us from Canada, where preventive cardiologists are non-existent. Well, just go see a regular cardiologist and tell them, listen, I don't want to ever see you in 40 years, especially not at 3 a.m. in 40 years. They'd be in the ER with him or Dr. Joel, and then he'd be calling me, and then we'd be taking you to the cath lab. Will this be posted somewhere? Yeah, the plan is to download this immediately afterwards, and we'll post it maybe on YouTube or some other platform that allows us to put long videos on it.
Yeah, we'll chop it up to give you some easy, accessible videos.
I was on Repatha and it stopped working. There's no way it stopped working. That's kind of strange. I was on Repatha and it stopped working. My doc said because it wiped my antibodies very fast. That makes no sense. Maybe you could use inclisiran then. The inclisiran is like Repatha. It's a PCSK9 that's a silencing RNA mechanism that lasts up to 6 months. So maybe have them switch you to inclisiran and see if that would make a difference if they really think that's what's happening. I don't know. Art Music is asking about preventive cardiologists in New Jersey, in New York area. I don't know. I think you could just do some Googling. But watch out for people who are just trying to sell you supplements, because there's plenty of those people who advertise themselves as preventative something. And then you go there and they're like, buy my blackwort, horseradish, lion's toenail fungus supplements or something. You don't want those people. I think I have most of the questions on my end. I think we've answered.
I think we've done a lot here tonight, and we're coming up on almost a couple of hours here. I know you're tired. You've had a long day. I've had a long day. I just flew in from work. So
yeah, no worries.
I want to thank you for taking the time. I can really see your passion in teaching, and we really need more education out here like this. So let's keep it going. Guys, give Dr. Alo a follow.
Are you on TikTok, just out of curiosity?
I am. I have an account there.
If we did this on TikTok, there'd be like 1,000 people on doing, asking questions and doing it. I have no idea why. Anytime I go on live there, it's between 300 to 900 people asking questions and listening.
I saw your TikTok account. You're very big there. So yeah, maybe we'll have to do that on TikTok.
You can easily post your videos automatically from Instagram to TikTok. We can chat offline if you want, but that's what I do. I just haven't. It's all automated. I only post to TikTok and it gets sent out everywhere. It's like I don't have to do anything.
Okay.
Super easy.
We'll do that for sure. All right.
Yeah. All right. Well, thanks for having me.
Thanks so much. I appreciate it. Get some rest. Have a good night. Thanks for joining, guys. Appreciate it.